This is the last part of the neuro unit, chapter 45. We're not doing the whole chapter. We are picking up on page 946 at traumatic brain injury and going to the end of the chapter. I know in the reading I initially had the wrong page number. I did not include the tumor and brain abscess, which is in your objectives, so I put a note out there that it's the entire chapter. I am going to do this in one sitting just because the majority is the TBI and there's very little after that. So I'm just going to go. Okay. So traumatic brain injury, this is just a chart that tells you the difference. Obviously, a traumatic brain injury is not due to other things. It's something that hits the head, impacts the head. This is just a good statistics on traumatic brain injuries, the major causes of it. Craniocerebral trauma, it can be classified as open or closed. Open head injuries result from skull fracture. TBI is any external force, not from a neurodegenerative or congenital condition. Brain injury occurs from both initial force of the head and the brain as a result of secondary force. Open traumatic injury occurs when the skull is fractured or when it is pierced by a penetrating object. In a closed injury, the integrity of the skull is not violated. The open can be different types of skull fractures with open traumatic brain injury or linear, depressed, open, and comminuted. A linear fracture is a clean break that either stays flat or points outward. A depressed fracture is pressed inward into the brain tissue. In an open fracture, the skull and dura are lacerated, creating a direct opening to the brain tissue. A comminuted fracture involves fragmented bone with depression in the bone tissue. A basilar fracture usually extends into the anterior, middle, or posterior fossa and can result in cerebrospinal fluid leakage. You will find leakage from the nose and the ears. This increases the risk of a CNS, central nervous system infection. Basilar fracture also is associated with increased risk for hemorrhage caused by damage to the internal carotid artery and damage to the cranial nerves 1, 2, 7, and 8. Closed traumatic brain injuries are caused by blunt force and can lead to contusions and lacerations of the brain. This is your coupe de coupe, the two injuries to the brain. This talks about your closed brain injury, your primary damage, and then your secondary damage, and I'm going to go more into the secondary damage. Your brain, this is your closed injury, different types of hematomas. Epidural hematoma is outside the dura mater of the brain. Subdural hematoma is under the dura mater, and intracerebral hemorrhage is within the brain tissue. There's venous bleeding into the space beneath the dura and above the arachnoid, most commonly from tearing or bridging of veins within cerebral hemisphere or from laceration of the brain tissue. Bleeding occurs more slowly in the subdural and mirrors the symptoms of an epidural hematoma. Post-concussion syndrome is addressed on page 947. This gives a good indication: the headaches, possible seizures, sleep disturbance, too much or too little, irritability, noise and light sensitivity, cognitive deficits, physical paralysis, motor deficits, diminished concentration, ADHD, anxiety or depressive disorders. You can have a mild injury and still have this post-concussion syndrome. These are persistent symptoms. They can last from days to months or to permanent. This is the levels of your injury, your mild, moderate, severe. I like this chart because it gives you a Glasgow Coma Scale, which I have on I think it's on your next slide, is your Glasgow Coma Scale and your consciousness, giving you specifics because you're mild, transient confusion or feeling dazed or disoriented, one or more of the following conditions: loss of consciousness for up to 30 minutes, loss of one or more, so they may not lose consciousness, because loss of memory or events immediately before and after, local neurological deficits that may not be transient. So one or more of those, no evidence of brain damage on a CT or MRI. Symptoms can include a wide variety of physical, cognitive problems, including this post-concussion syndrome, mild traumatic brain injury. More information, key features are on chart 45-7 on page 948. On your moderate head injury with your Glasgow Coma Scale initially being between 9 and 12, is associated with loss of consciousness for up to a day. It's anywhere from loss of consciousness from 30 minutes up to 6 hours. Glasgow Coma Scale 9 to 12. Often but not always, focal or diffuse brain injury can be seen on the MRI or CT. Post-traumatic amnesia, memory loss, may last up to 24 hours. It can be either a closed or open injury. And then you're severe with your Glasgow Coma Scale of 8 or less, associated with loss of consciousness for more than 24 hours. Your text says loss of consciousness longer than 6 hours. Focal and diffuse damage to the brain, cerebral vessels, or ventricles are common. Both open and closed injuries can be focal or diffuse, usually extensive, noted on the CT and the MRI. They'll be in critical care. High risk for secondary brain injury from cerebral edema, hemorrhage, reduced perfusion, and biomolecular cascade, which I'm going to talk a little more about. Here's your classification again with the Glasgow Coma Scale to help you on the mild, moderate, severe. Be familiar with your Glasgow Coma Scale. Okay, so traumatic brain injuries, delayed or indirect brain damage, preventable damage from the other things, hypoxemia. You need to protect the airway and their breathing, immediate fluid resuscitation because they have damage from hypoperfusion and shock. Keeping the head of the bed at 30 degrees because of brain swelling, edema, contusion, bleeding. Antibiotics immediately if there is a skull fracture, diazepam, and protecting the airway due to seizures. The secondary injury includes any process that occurs after the initial injury and worsens or negatively influences the patient outcomes, most commonly due to hypotension and hypoxia, increased intracranial pressure, cerebral edema. Hypotension is considered an arterial blood pressure less than 70, and hypoxia is your PaO2, arterial O2 of less than 80. Hypoxia can be due to respiratory failure, asphyxiation, loss of airway, impaired ventilation, which leads to decreased flow, increase, and it's just a big cycle where everything aggravates everything else with the perfusion and hypoxia damage, leading to increased intracranial pressure. Here's another picture that goes over your secondary brain injuries, sometimes after impact, often preventable. Hypoxia, which I told you that 80, hypotension here it says less than 90, your text is less than 80, raised intracranial pressure greater than 20, and metabolic disturbances. Here's more on your secondary injuries, the hypoxia. Hypercapnia, which is your CO2. Your text talks about that too, about the CO2 being a potent vasodilator don't know if I said PO2 or PCO2. PCO2, potent vasodilator, which increases your cerebral blood flow and increase ICP. So you want to keep your PCO2 between the 35 and 45, not letting it go. When I correct that, keep your CO2 low. You want it between 35 and 38 on a traumatic brain injury patient, 35 to 38. Then your hypotension, overall blood loss contributes to cerebral hypoperfusion. Also, it talks about your CPP, cerebral perfusion pressure, the pressure gradient over which the brain is perfused. You need to keep, well, there's a calculation. You don't need to know that calculation for that. Okay, this is just a good picture of all the multiple things you need to be monitoring and watching on this patient, keeping their airway, keeping their CO2, keeping their head at 30 degrees, SEDs because they're not mobile, preventing deep vein thrombosis, monitoring the brain, the ICP, their skin, their multiple things. I'm just going to keep moving here. Okay, so your neurological assessment, your Glasgow Coma Scale, your pupil size, doing your cranial nerve assessment, and I have a slide later that actually goes into it a little better than my previous slides that I thought might be helpful. Of course, your airway is the most important, airway breathing, circulation. More serious injuries, the more severe the impact in autoregulation and the ability of cerebral vascular to modify its pressures. You want to monitor the blood pressure. Oh, I have the Cushing's triad coming up. Okay, here's another picture of the Glasgow Coma Scale for you. Your neurological, doing your cranial nerves, cerebral function, mental status, appearance, behavior, cooperation, level of consciousness, language, emotional. It's all in your Glasgow Coma Scale. Really, if they are a mild to moderate and not on a ventilator, you can do balance gait, finger exams. This goes over the whole slew of checking things. This is a good picture I found on cranial nerves simplified. They may give you some ideas on learning that. This is your decerebrate and decorticate posturing, which is on page 952. You're assessing the motor response. Deterioration in the motor function and the development of abnormal posturing. Decerebrate or decorticate posturing or flaccidity is another indicator of progressive brain injury. The decorticate is the hands are coming to the core, they're coming inside, and the feet are flexed. Everything is flexed inward, and the feet pointing out. Decerebrate posturing is when they are pointing outward. The hands go out instead of clinging to the core. They're extending out, or they're leaving. When they are decerebrate, they're right after that is flaccid. Okay, intracranial pressure monitoring. You're going to have tissue swelling, they can be bleeding, you can have cerebral spinal fluid leaking, all these things that are affecting the intracranial pressure. Normal is 10 to 20. This is another picture of putting in an ICP. It is a sterile procedure, but it can be done at the bedside in ICU. This is just a good picture on what to look for. You see the posturing, decerebrate going to decorticate, extending to flaccid as it gets worse. Your eyes, each of these are as it progresses from papilledema to pupillary changes to impair eye movement, your seizures, headaches, Cushing's triad, which I've got on one of these slides coming up, vomiting from intracranial pressure. Here's your Cushing's triad. which is mentioned on page 952. It's a classic but late sign of increase intracranial pressure, severe hypertension, widening pulse pressure. The other lectures I talked about the shortening, lessening pulse pressure. This is a widening, your systolic's going up, your diastolic's going down. It's a widening pulse pressure. So this is a good picture showing you the difference between shock and increased ICP, Cushing's triad, which is the exact opposite. Blood pressure's going up, heart rate and respiration's going down. Hydrocephalus or cerebral edema is another complication. It talks about that starting on page 945 in your text. Abnormal increase in the cerebral spinal fluid. There's communicating, non-communicating, just knowing that it is that increase in fluid. The ventricles may dilate from relative increase in cerebral spinal fluid. It can lead to brain herniation. There's a shift of one or both areas of the temporal lobe known as an uncus. This shift creates pressure on the third cranial nerve. Late findings include dilated or non-reactive pupils, ptosis or drooping of the eyelids, rapidly deteriorating level of consciousness, or there is a central herniation which extends into the brainstem. It's manifested by Cheyne-Stokes respirations, pinpoint and non-reactive pupils, hemodynamic instability. All herniation syndromes are potentially life-threatening, or they will die. Okay, so here, general monitoring, the EEG, keeping your continuous pulse ox on, your arterial gases, PO2 of greater than 80, you're continually monitoring their CO2. Remember, you're wanting to keep it 35 to 38 PCO2, central venous pressure, systemic temperature. Again, you're looking at Celsius. Remember, your 101 degrees is 38 degrees Celsius. They may or may not have fluctuations or inability to control their temperature. Patient may develop a fever, result of systemic trauma, blood in the cranium, or generalized inflammatory response to the brain injury. It can be an infection. A third cause is central fever caused by hypothalamic damage. This type of fever is high, lasts several days to weeks. The temperature stays above 101 or 38 degrees. Giving them sponge baths, acetaminophen or aspirin. Fever from any causes associated with higher morbidity and mortality. It talks about this therapeutic hypothermia that sometimes is used to keep the core temperature 32 to 34 degrees, but you have to be very careful and meticulous with the rewarming process. I didn't do a lot of neuro, so I'm not real familiar with that hypothermia. But you are watching for hyperventilation is to be avoided. Sometimes it's needed in the first 24 hours, but that has to be carefully watched. I told you about the CO2, O2 sat, aggressive respiratory management. Keep your head of bed at 30 degrees, prevent aspiration, prevent hypotension, use pressors if necessary. Patients with severe TBI often die. How is TBI treated? Diuretics, anti-seizure medicines, coma-inducing medicines, surgery. I'm going to go through these. So here we have osmotrol. I'm so used to calling it mannitol. Osmotrol talks about this on page 954 in your text under drug therapy. It's not osmotic diuretic. It is not a continuous infusion. It is given in boluses and followed with furosemide. So it pulls the fluid out. It's for cerebral edema, and then to prevent fluid overload in the rest of the body. It is followed by furosemide. So of course you're going to watch for fluid electrolyte imbalances, because of especially with a loop diuretic, with your potassium, glucocorticoids such as dexamethasone, methylprednisone are not beneficial to decrease the inflammation in the brain. I said watching your osmolality, watching your serum electrolytes, having a Foley catheter, strict INO, may use sedatives such as propofol to keep them down. I'm going to talk about the barbiturate coma, morphine or fentanyl. Fentanyl has fewer effects on blood pressure and heart rate, so it is much safer. Although naloxone is an opioid reversal, you do not want to give this on a TBI patient. If you've ever given naloxone, it is an immediate effect. They wake up suddenly, fast. It's rough. Antileptics may or may not be used, usually if they really have had a seizure or high risk, depending on where the bleed or the injury is, because they don't routinely give them like phenytoin for seizures. Here, this talks about the barbiturate coma. Phenobarbital seems to be the best one. That's the only one your text talks about also. It's difficult, of course. You can't quite do the neuro checks. Complications are decreased GI motility, cardiac dysrhythmias, hypokalemia, hypertension, and fluctuations in body temperature are all from this barbiturate coma. Maintaining fluid and electrolyte balance. Watch for diabetes insipidus. I have a slide coming up on that. Okay, another is doing decompressive craniectomy. They can do that to just remove the clots, just to remove pressure. It's not done that often. All devices are inserted through a burr hole, also known as a keyhole craniotomy, strict sterile technique. That's the ICP, decompressive craniectomy, removal of section of the skull, followed by immediate skull closure to remove ischemic brain tissue, or it may be to remove a clot. That's like a last resort. Goals of therapy, your mean arterial pressure, remember I said is your 2 times your systolic plus your diastolic divided by 3 gives you your mean arterial pressure. Keeping your CVP between 5 and 10, that is appropriate fluid volume. Your sodium, do not let them go into hyponatremia. I'm going to talk about that more in a minute. And SIADH and hyponatremia and seizures. There will you watch the glucose, because again they can have an elevated glucose. Keep between 100 and 180. Hemoglobin is 7, hematocrit 21, sedation, keeping your core temperature 36 to 37. O2 sat, ICP, I think I've covered all of these. Watching your coagulopathy, platelets should be really greater than 100. Oh, this is if you're going to do operation, really greater than 100. Neurochecks, ICP, perfusion, talked about all these. Oh, go back. I guess I didn't have a slide. I thought I had a slide. Yes, I do. The SIADH and other complications, I do talk about that with your brain tumors. Sorry, got ahead of myself. So here, your brain tumors, this is the primary tumor originates from the brain, not very common. The secondary comes from outside of there. Most common brain tumors are listed here. Primary, oh, I did that. Meningioma is the most common brain tumor. 3 to 1 women versus men. regardless of the type of tumor or where it is. It can cause cerebral edema, tissue inflammation, increase intracranial pressure, neurological deficits, hydrocephalus, and pituitary dysfunction. Everything that we've really been talking about with the, except for the pituitary, with the traumatic brain injury. The symptoms, there's table, no, that's not it. Common brain tumors are listed in table 4510. I thought they had a list of symptoms in here. Here we go. Headaches are usually more severe and awakening in the morning, nausea and vomiting, visual symptoms, seizures or convulsions, facial numbness or tingling, loss of balance or dizziness, weakness or paralysis in one part or one side of the body, difficulty thinking, speaking, articulating, changes in mental personality, and papillary edema, which is swelling of the optic disc, which shows increased intracranial pressure. Meningiomas being the most common benign tumor. You can have acoustic neuromas in the cranial nerve 8. Classification of your tumors. Table 45-6 goes over the benign versus the malignant. I don't think you need to memorize those. Management of brain tumors, non-surgical management, usually with drug therapy such as chemotherapy. I'm not going to go into the different kind of drugs. Analgesics, codeine, and acetaminophen are given for headache. Dexamethasone to control cerebral edema. Phenytoin or other anti-epileptics for preventing or controlling seizures. Proton pump inhibitors to decrease gastric acid secretion and prevent development of stress ulcers. The gamma knife, again, which is discussed on the bottom of page 959 into page 960. A type of non-invasive treatment. Of course, there's surgical, which with craniotomy, which is an incision into the cranium to remove the tumor or alleviate part of it, to take some of the pressure off, alleviate some symptoms. Post-op, adequate respiratory ventilation, arterial pressure monitoring, evaluating cerebral edema, temp control, medicate for headache, the anticonvulsants, phenytoin, diazepam, preventing aspirations. Let's see. Concerns are centered on the possibility of increased neurological deficits after the surgery in the patient's self-image. Check that the patient has not had alcohol, tobacco, anticoagulants, or NSAIDs for at least 5 days before surgery. They try to use minimally invasive post-op, looking for periorbital edema around the eyes. It's common or not unusual to have ecchymosis or edema around the eyes. Do cold compresses for the swelling. Critical care has cardiac monitoring for dysrhythmias because they may affect the autonomic nervous system and cause some electrolyte imbalances and dysrhythmias. Of course, electrolyte imbalance aggravates the rhythms more. Expect fluid restrictions to 1,500 mLs at least in the first 24 hours if they're dealing with a pituitary tumor or in that area. Repositioning. Let's see here. Did not mean to do that. Got ahead of myself. Let me get back. Oh my goodness, I can't believe I did that. Okay, here we are. SIADH, syndrome of inappropriate diuretic hormone. DI is diabetes insipidus. Those are big things to be watching for. Your text has a whole section on it on page 961. You're monitoring your CBC, your electrolytes, osmolarity, coags. Hyponatremia, low serum sodium may occur, result of fluid volume overload or syndrome of inappropriate diuretic hormone, SADH, or steroid administration. Hypokalemia needs to be watched for. Hypernatremia may be caused by meningitis, dehydration, or diabetes insipidus. So your hyponatremia with SADH. Okay, so hyponatremia, muscle weakness, restless, extreme thirst, dry mouth. This is all like SADH. Additional signs are decreased urinary output, untreated. Hypernatremia. Untreated hypernatremia can lead to seizure activity. Actually, hyponatremia also. Diabetes insipidus should be considered if the patient voids large amounts of very dilute urine with an increase in serum osmolality. On here, your SIADH, hyponatremia, hypoosmolarity, restrict your fluid intake. And with diabetes insipidus, you want to increase your water intake and use vasopressin. This breaks up does a real good job on distinguishing diabetes insipidus, SIADH, and CSW. Your CSW is cerebral salt wasting. It's on page 962. Thought to be the result from influence of atrial natriuretic factor, or ANF. CSW is believed to be the primary cause of hyponatremia in the neurosurgical population, characterized by hyponatremia, low sodium. Know your sodium levels, decreased serum osmolality, and decreased blood volume. Serum vasopressin ANF levels can differentiate between whether it's CSW or SIADH. CSW is treated with replacement of sodium isotonic normal saline fluid volume. It's extremely important to do accurate weight measurements, watching for fluid overload or dehydration. Here's another picture which distinguishes between the CSW and SIADH that you might find very helpful. CSW, orthostatic hypotension, where SIADH blood pressure is normal. In CSW, or cerebral salt wasting, your CVP is decreased. SIADH, it's elevated. CSW, both of them have tachycardia, both have low serum osmolality, urinary sodium, and urinary volume. But your uric acid is elevated in the cerebral salt wasting, where it is low in SIADH. Cerebral salt wasting has a decreased weight. SIADH has an increased weight. Some more things post-op nursing consideration. Of course, your strict vital signs, your neuro evaluations, neuro checks, cranial nerve assessments. Patient may be lucid during the first 24 hours and experience a decrease in loss of consciousness during this time. Okay. I'm now going into your brain abscess, bottom of page 962, and progresses over it. It's a purulent infection of the brain in which pus forms in the extradural, subdural, or intracerebral area. This is a good picture here, telling you male greater than female, peak incidence 3rd to 5th decade, up to 25% of abscesses are cryptogenic and have no clear source. The typical source, according to your text, is a lung infection, although it is common not to find the source. It can originate from organisms in the ear, sinus, mastoid area and enter the brain. A portion of the abscess can also come from a distant organ, such as heart or tonsils. and break off and enter the systemic circulation. It's a septic emboli and contain organisms that get lodged in the cerebral vessel and produce a localized infection. Penetrating trauma, open head injuries, and neurological procedures are also potential for infection. Once the organism gets in, within a few days, necrosis of the tissue takes place, pus forms, and the tissue liquefies, followed by development of cerebral edema, localized vascular congestion, tissue swelling in response to inflammation. During the next few weeks, the area becomes encapsulated. Streptococcus is the most common. You can have these in AIDS patients for numerous reasons. Here's the three mechanisms: direct extension, hematogenesis, which is the seeding coming from a septic emboli, and then penetrating. Here's your symptoms of a brain abscess: symptoms of increased intracranial pressure. You have list of key features, chart 4511 in your text: headache, fever, pain, motor deficit, ataxia, sensory impairment, aphasia, seizure activity, visual field changes. And with severe, having the signs of increased intracranial pressure. The most frequent presenting symptoms are listed here as headache, drowsiness, confusion, seizure, hemiparesis, speech difficulty, and rapidly progressive course. Medical management: controlling the ICP, draining the abscess, lots of antibiotics, diagnostic imaging. Assessment is your white blood count, doing your SED rate, ESR, which is an inflammatory marker. If the abscess is encapsulated, the white blood count will not be elevated. CT scan to look for changes. EEG can locate the lesion in most cases and shows high voltage, slow wave activity. Interventions may have to drain the abscess. May pay to a shunt in if they developed hydrocephalus. Antibiotic dosing goes on for an extended period of time. They use a combination of antibiotics. They will use anti-epileptics such as phenytoin to prevent seizures. Physician may surgically drain encapsulated abscess via a burr hole to reduce mass effect. In certain cases, a craniotomy may need to be performed. Strict neuro checks and education. The last section of this text: acquired hypoxic anoxic brain injury caused by a reduced or absent supply of oxygen to the brain. Common causes: cardiac arrest, asphyxiation from a suicide attempt, near drowning. They don't call it near drowning, they now call it drowning. Drug use, overdose, accidental electrocution, severe asthma. The neurons in the brain experience ischemic injury, and cell death is within 4 minutes of reduced oxygen supply to the brain. Generally, hypoxic anoxic brain injury results in a decrease in cognition, mobility, and sensation that occurs with the event and persists in an unpredictable manner. MRI provides diagnostic tests to determine the extent of the injury. It is not common for patients to experience increased intracranial pressure from cerebral edema in the days following. Is not uncommon. Sorry, I was like not common. It is common for them to experience an increased intracranial pressure from the hypoxia resulting in cerebral edema. Increased pressure in cerebral edema further damage the results of this. And that is actually the end of chapter 45, the end of the neuro. I decided this was a good one to put in there, a traumatic brain injury, because nurses are in the ideal position to do education, especially in these areas with people on these ATVs with no helmets. And like my husband's best friend since childhood, riding a motorized bicycle with no helmet, fell and has a bleed in his head that they're monitoring at this point. It's so easy to happen, and we can educate. And that is the end of this lecture and the end of neuro.